Hello friends, today we will discuss about anomalies of pulmonary venous connection. They can be total or partial. Normally in the heart, four pulmonary veins, two right and two left. They drain lungs into posterior wall of left atrium. TAPVC is group of cardiac malformation in which all of the four pulmonary veins drain into right atrium directly or indirectly via joining any inflow to right atrium, that is, it may be superior vena cava, inferior vena cava or coronary sinus. Based on site of connection, four types of TAPVC exist: supracardiac TAPVC, infracardiac TAPVC, cardiac and mixed one. Why it is important to check for TAPVC? Obstruction to pulmonary venous return is common association in TAPVC. It is seen in around 50% of cases. In case of obstruction, venous return to pulmonary vein is impaired, leading to increased venous pressure, congestion in lungs, pulmonary edema, and pulmonary hypertension. Hemodynamic consequence of anomalous pulmonary venous connection is important in neonates as it leads to mixing of blood and cyanosis after birth. Delay in diagnosis of TAPVC and surgical repair leads to high rate of neonatal morbidity and mortality because of pulmonary edema, hypertension, and cardiac failure. Prostaglandin therapy to maintain ductus arteriosus is contraindicated in TAPVC. What are diagnostic clues? In grayscale, in four-chamber view, when suspicion of rhinoisomerism is there, TAPVC should be looked for. TAPVC is commonly associated with other malformations like dextrocardia, single ventricle AVST. In absence of isomerism, fetal heart with TAPVC may show disproportion between right and left sides of heart, with slightly smaller left atrium and left ventricle due to decreased venous return to left side of the heart. A direct sonographic sign in TAPVC is absence of connection between pulmonary vein and posterior wall of left atrium, and left atrium posterior walls looks smooth. One of the main clues for diagnosis of TAPVC is to see a venous confluent chamber called confluent vein with parallel course to the posterior wall of left atrium. It is also called Twigg sign. In TAPVC, space between posterior wall of left atrium and descending aorta is increased. This space is known as post-left atrium space index. It is calculated as distance between left atrium and aorta divided by diameter of aorta. Normal values are around 0.62. Values more than 1.27 are seen in cases of TAPVC. In color Doppler with low velocities, TAPVC show different velocity pattern in spectral Doppler than that in normal pulmonary vein. Normally connected pulmonary veins show typical triphasic pattern, but in TAPVC it shows non-pulsatile continuous or biphasic flow. In obstructed TAPVC, there is Elias color Doppler in pulmonary vein along its way to final connection, as well as flow velocities in vertical vein are more than 0.5 meter per second. Other specific signs. In supracardiac TAPVC, there is fourth vessel which is vertical vein to the left of pulmonary artery in three vessel trachea view. This vein drains to dilated left brachiocephalic vein which is further going right to drain in superior vena cava. Dilated brachiocephalic vein reflects increased blood flow due to drainage of total pulmonary venous flow. In cardiac TAPVC, there is seen dilated coronary sinus. In axial four-chamber view, there is dilated confluent vein behind the left atrium. In inferior axial plane, there is drainage of confluent vein to the dilated coronary venous sinus. In infracardiac TAPVC, in longitudinal view, in color Doppler, additional vessel is seen in liver entering through esophageal hiatus in between IVC and descending aorta. Flow is seen in this additional vessel from thorax to abdomen with parallel course along aorta. It may drain into umbilical vein, portal vein, DV or hepatic vein. In axial abdominal situs view, additional vessels seen between IVC and aorta. In mixed TAPVC, there is mixture of supracardiac and infracardiac connection. There may be ascending as well as descending vertical vein, or there may be no pulmonary vein confluence, but rather individual pulmonary veins which drain independently to various systemic venous connections can be seen. In partial anomalous pulmonary venous connection, it is characterized by direct or indirect drainage of 1, 2, or 3 or 4 pulmonary veins into the right atrium. It is difficult to detect and has been rarely reported prenatally. It is associated with Smithers syndrome. Smithers syndrome is combination of hypoplasia of right lung, right pulmonary artery and PAPVC. It is suspected in 4-chamber view by dextrocardia and small hypoplastic right lung. Right pulmonary veins drain into IVC instead of left atrium as shown in longitudinal view. It is also called Smithers vein. Because of hypoplasia of right pulmonary artery, systemic arterial blood flow to right lung can be seen as in pulmonary sequestration. In differential diagnosis, any cardiac condition that causes chamber disproportion between right and left sides of heart should be considered as DD. An IVC interruption with azygous continuation results in enlarged azygous vein, which may be misleading as confluent vein. Persistent left superior vena cava in 3-vessel trachea view may look like a supracardiac TAPVC. We can distinguish between two, as in PLSVC, flow will be towards the heart, but in vertical vein, flow is in opposite direction. In third trimester, amniotic fluid within bronchial tube during fetal breathing may mimic a confluent vein, but spectral Doppler can differentiate between two by showing bidirectional flow during inspiration and expiration in bronchial tree, but unidirectional venous flow within confluent vein. Associated anomalies. Pulmonary venous anomalies are frequently found with other cardiac anomalies. In 28% of cases, TAPVC is related to venous sinus AST, although seldom identified antenatally. AST, VST, single ventricle, coarctation of aorta, HLHS, and other cardiac defects are commonly seen in association with TAPVC. Extracardiac anomalies are common in TAPVC with heterotaxy, but less in non-heterotaxy patients. Single gene disorder like Noonan syndrome, Holt-Oram syndrome are reported occasionally with TAPVC. Cat eye syndrome, characterized by preauricular tag, coloboma, anal malformation, is reported very commonly, around 40% in TAPVC. Now its prognosis. Prognosis depends on type of aberrant vein connection, like it is supracardiac, infracardiac, or cardiac. Existence and extent of pulmonary vein obstruction, which is more common in infracardiac TAPVC. Presence of other cardiac and extracardiac anomalies. Outcome is uniformly fatal as postnatally ability to reconnect multiple anomalous pulmonary veins together is very challenging, with extremely high risk of recurrence of pulmonary vein stenosis. Prognosis of newborn who survives through surgical correction is good. These are my references from where I have taken the content. Thanks a lot for patience listening.